Just wanted to start off by introducing myself. I've worked in the NHS primarily for this part of my role, and I've transferred into veterinary settings now. A lot of the situation is very similar, but a lot of things are very different in patient safety, in human medicine and in veterinary care. I also mentioned I'm not clinical, so all of our talks today are by nurses for nurses, apart from mine. So I have my nurse who works with me as our patient safety assistant, who is half her time clinical in our ICU and in ophthalmology, and also half her time working with me on patient safety and our learning around that. So I'm very grateful you can step out of ICU today, part of my shift, to join us for this session. To just start off, recap on what we mean by patient safety. I often talk to people about my role and ask them, what do you think is meant by patient safety? And I very often hear the response, keeping patients safe. It's probably a little bit more to it than that. So I've highlighted some of the key phrases in this definition from the World Health Organization here. So it's the absence of preventable harm, so harm we can do something about and try and prevent happening, to our patients, reducing risk, and that's basically what this is all about. It's about identifying risk, trying to reduce risk, and what it says here at the end, to an acceptable minimum. It's accepting that harm will come to our patients through the provision of healthcare. That's part of the fact that healthcare is a very complex system. We're dealing with a lot of diseases, a lot of drugs, a lot of complexity in healthcare, and things will and can do go wrong. But part of my role is to try and minimise the risk in this building and try and keep it to a minimum. And when things do go untoward, is to try and learn from those and see what we can do to potentially change things for the future. My role here is quite rare. As far as we're aware, the Ralph is the only hospital that has a dedicated full-time patient safety lead in the UK. So it's one of the reasons I took the role, because I want to help develop these concepts in veterinary settings and to help catch up the veterinary sector to the human healthcare sector, where this has been a key concept and a key area of learning and research for a good sort of 20 years now. So it's a really good demonstration of the commitment that the Ralph has to patient safety, because that's all a big part of patient care experience as well. Providing what we have here at the Ralph is being a centre of excellence and compassion, and safety is critical and core to that as well. So today I want to talk to you about medication error, and the reasons why. I think firstly that we don't talk about it enough. It is absolutely ubiquitous. It occurs in every healthcare setting, both human and veterinary, be that in ambulances, hospitals, general practice, your referring vet practices, and in referral hospital settings too. It happens everywhere, and it involves every type of person involved in the medication process as well. So we all are affected by it. It's something we, if I talk to clinicians when errors have happened, or even in my induction sessions that I do with all of our new starters, I talk about this concept, and it's very rare I come across a clinician, be it vet, nurse or other, who hasn't either been involved in, witnessed or made a medication error themselves. So it's something that is very common to us all. It's also, it's that common that the World Health Organization have made medication without harm the topic of the Global Patient Safety Challenge. It's something that's it's one of the biggest risks to patients in healthcare settings. So it's a big area of focus and continuous research and development. It is medication error is the cause of around, different research studies show between 30% and 70% of all patient safety incidents. So it's a significant part of patient safety errors. And actually here we obviously monitor and we report our incidents. Here we use a system called VetSafe that many of you will also be familiar with. And I've done a little bit of an audit of that recently, and 1/3 of our incidents here are medication error related. I also think it's something that can be reduced, but I don't think it can necessarily be completely stopped because of the complexity of healthcare. I'm reminded by, I remember years ago, Volvo, the car manufacturer, had an ambition statement to have 0 accidents in its cars. And it's like, well, is it actually achievable? Can we actually definitely look to realistically sustain having 0 medication errors? I'm not sure that we can, but we can definitely do stuff to reduce it. And that's what I'm going to talk about more today as well. Some of the strategies and the tools and techniques we can do to try and minimise medication error, and how we can also reflect and learn from them when they do occur. The main reason I want to talk about medication error to you today, though, particularly to you as nurses, is because of the impact on the people who make the error. This here is Rolo on the left and Smokey on the right. They are different patients. One of the big things I mentioned, the differences between human and veterinary healthcare, is that we have similar patients who look the same, often with similar names and similar breeds, and getting patients mixed up is much more of a prevalent thing than it is in veterinary than it is in human settings. You know, they won't tell you, I'm not Roly, I'm Smokey. And these two patients were with us with our wonderful neurology team having their spinal surgery, and I had a student nurse self-report that she had given Smokey's medication to Rolo by mistake. It was gabapentin and paracetamol. The patient was fine. They are, and one of the good things about medication is the vast majority of the time it is a no harm situation. It doesn't cause a significant harm to patients. Obviously, it can do. The wrong drug to the wrong patient in the wrong setting can cause a problem, but in the vast majority of cases, it doesn't. And the student nurse did exactly the right things. I like to recognise the good practice where I see it. She put the report in, but actually at the time, she checked with the vet to make sure that the patients were okay. When she came to talk to me about it, what really struck me is how she felt. The patient was fine, had come to no harm, but she felt absolutely awful. And I know that every person I speak to who's made a medication error feels awful, even if the patient is fine. So just to take a second to reflect on that and think, it's okay. It happens to, I think nearly everyone in this room will have had this situation happen or something similar. And the reason I want to talk about it more and raise the awareness of this topic is because of how it makes people feel. And also, I want to make sure patients are okay, that they're kept safe, of course, but also about the well-being of our staff, and making sure that the first thing I always ask to somebody who's put in a report about medication error is, are you okay? Because very often they don't. They go home, they've cried, and by the next day they feel better, but it does have that shock and that impact at the time. So, as I mentioned, the medication process, break it down, it's actually more complex than you think. There are multiple steps involved and multiple people involved where things can go wrong. So from the very first point, prescribing. The person who's making the prescription, choosing the correct drug for the correct diagnosis, making a prescribing error, typing the wrong numbers into the prescription or handwritten, miscalculating a dose. These all things can go wrong at the very first stage of deciding what to prescribe. Then we're dispensing the medication, be that yourselves or be that here we have our dispensary staff who support that within our hours. Out of hours it's our nursing team very often who will be dispensing drugs. We can often dispense the wrong drug or the wrong dose. We then have to deliver that medication either to the patient's medication storage, or we might send medications to carers at their home address. So making sure the right medication gets to the right patient's location. We are then administering the medication and giving it, so we can potentially give the wrong dose of something, we can give an extra dose of something or double dose of something, we can set up a CRI at the wrong rate, and again, look, with Rolo and Smokey there, we can give a drug to the wrong patient. And then finally, with monitoring. When we're given a drug, we should be monitoring to make sure the effects of that drug have been effective, and also picking up if there are any adverse reactions. We also want to have adverse reactions reported so they can be fed back to manufacturers in cases of batch error or something with a particular drug. So there's different people involved at different stages in this process. So again, healthcare is complex and there's complexity in this system and lots of potential for error and where things can potentially go wrong. So medications happen, they happen here, they happen in your practice. Again, I mentioned I did a bit of an audit here to see what types of things can go wrong when with our medication errors, and we had in the last 6 months 57 that were reported to me. It's probably at least double what that actually potentially happened, because levels of reporting is a whole other topic I could talk to you about. But around half of those are dose errors actually, getting the wrong dose of something. So we keep an eye on this and look at the ones that go wrong. But the real question is, what can we do to reduce this risk? What can we learn from these situations? We report them, but what's the point of reporting it? So we can identify what's happened, look at the contributing factors and why, so we can potentially either make a change to something, a change to a process or a practice, or what we can learn from something that's happened. So there are some techniques that we can think about. So this is the 5 rights of medication. It is quite a well-known framework for trying to be a mental prompt when at any point in that multi-stage process of giving a medication to a patient, thinking about, have I got the right things here? Have I got the right drug? Am I double checking that drug against the treatment sheet? Am I getting someone else to double check it for me or countersign it? That I have definitely got the right drug that I intend to give? Have I got the right dose that's intended as well on the prescription? And we're delivering this medication by the right route, be that oral, topical, IM, IV, subcut, making sure we've got the correct route of administration. Is it being delivered at the right time? That might be the frequency or the intervals of medication that's been scheduled, or the rate of the CRI that's been set. Is that all correct? And also the correct patient. So have we got the correct patient? Have they checked their ID collar, or their kennel signage, or the medication storage, to make sure we've given the right drug to the right patient. And as part of our giveaways, we have some posters, which will still have some more left there, which you can take away and put up in your practice in your dispensing area, which can help be a bit more of a mental prompt on the wall there for you to refer back to. So thinking about the 5 rights, there are versions that have 7, 8, 10 rights, but I think keeping it to the basic 5 is one for each finger, so you can think about it in that way. Countersigning. So I know this doesn't always take place. We audit this here and we are getting up into 90% of having all our medications appropriately countersigned. If I had a magic wand, I think I would make sure that every drug was countersigned every time. And by drug, I mean something's been prescribed. That includes procaine and fluids, everything that's prescribed being dispensed and then checked by a second person every single time. And also to support and enable you as well, that if you are going to collect the patient's medications and you see the box or bottle has not been countersigned, to empower you to either go and verify that medication and get it double checked, or to dispose of it and redispense it so you can double check that you know that the drug that you're giving to that patient is the correct drug. We do have reports of near misses where countersigning has caught a wrong drug or dose being dispensed. So it does happen, it can happen very frequently, particularly we've got hundreds or thousands of medications being dispensed every week. There will be mistakes made. So to protect you and give you the assurance that you know you're giving the correct drug to that patient, making sure that drug has been countersigned is a really critical way of doing that. And obviously we're checking not just the drug itself, but we're checking the strength of that drug, the formulation, tablet, capsule, liquid, the quantity of the medication. Countersigning includes tipping out the pills and counting the pills as well, and making sure you get the right quantity of something, and that the expiry date is in date as well. So countersigning is critically important, and also anyone can do it. Hasn't got to be someone clinical that countersigns. We have our reception staff here. I do it quite a lot as well. A lot of our non-clinical team who work upstairs in their office have had some training on countersigning too, so they can support when there's fewer people around. There are more people around who can actually help with countersigning, because it's something that gets missed when there's fewer people about. Also, when drawing up medications, having someone double check it for you, and that's also the drug, but also the mixing agent that you're mixing the drug with. Having a second person replay back to you what you've drawn up, and using that open question of what have I got here, not saying have I got such and such, because that open question, what have I got here, having someone read that back to you, is that audible prompt of, oh yes, that's what I intended to draw up. So that's again, that magic wand, having every drug double checked every time would be something that I would advocate. And I know that when it gets busy, this is one of the things that sort of slips off the radar, and there's few people around or lots of patients to deal with. But that's when it's even more critical and even more important to do this, because when you're busy and rushing, you're more likely to pick up the wrong thing. So making sure you're getting medications double checked is really important. Particularly for handwritten prescriptions and medication, anything written out by hand, thinking about leading and trailing zeros. So a leading zero is where you have a drug dose that is smaller than 1. You should always put 0.5 or 0.2 and have that 0 point before the decimal point, because as you can see on that example there with the drops in, there is a decimal point, but it's hidden by the little line there, and could be read as 5 milligrams rather than 0.5 milligrams. So always using a leading zero for a drug dose that's smaller than 1. And on the right hand side here, trailing zeros for a whole number should not be used. So 1.0 could be read as 10 quite easily. So not using a trailing zero for a whole number, and always using a leading zero for a number smaller than 1. Abbreviations, being really careful with abbreviations when we're writing out medications. The most common one, this is a sample of a very long list of medical abbreviations that is advised not to use. So the top one, the microgram one, is probably one of the most common ones we see misinterpreted for milligrams rather than micrograms. So actually using mcg instead. And the other one is unit or IU being mistaken for IV. These are examples here, and for drug name abbreviations as well. If we have the key takeaway here is if you have the space to write the full instruction or the full medication name, then do so. It's much more easy for someone else to read it and pick up the correct instruction, and to write the complete drug name, or to write once daily, twice daily, rather than BID, except for example, because that's more clear and it states exactly what you intend to happen. You may have not seen this before. This is called tall man lettering. It's for look-alike, sound-alike medications. So where you have these, there's a list that's published by the US Federal Drug Administration. Have a list of drugs where this is useful to put into your clinical systems, to highlight parts of the word that can be mistaken for each other, and to help distinguish between vincristine and vinblastine, for example, to highlight those letters that stand out and make the words visually more distinctive. So there's things we can do, and sometimes there's things we can change when we have a medication error. I have changed the type of medication vials that we use before, and the size of bottles. I've changed how we store medications. We've brought some new drug labels in. Things we have done as a result of learning from medication error, but sometimes there isn't actually anything we can change. What we can always do though is learn. But as this quote here says, we don't just learn from experience, we learn by reflecting on our experience. And when we talk about reflection, I know you have to do your CPD, and reflection is now part of your CPD sort of requirements, and it can be a bit of an eye roll, a tick box sort of check box process. But if paid attention to and done with a good framework, it can be a really useful way of learning from something. And also to learn from things that are things that haven't gone well, like a medication error, but also things that have gone really well. So you've had a really great case or a great outcome, or a new technique that you've tried, or something you've taught to somebody else that's gone really well. You can reflect on positive and negative experiences, and still learn from those and get the best from it. Reflection is for anyone as well. It's for you as nurses, but also vets, but also non-clinical staff. I'm non-clinical, I've worked in management for a lot of years, and I still do reflection with things go well with my team and things like that, so it's valuable for anyone that's part of your practice. I do recommend it though for every report I receive about a medication error. I include the 5 rights as a little prompt reminder, and also I include a link to a reflective practice tool that I'm going to talk to you about now, because it is sometimes the only thing we can do to help that nurse that's made that report of giving the wrong drug to the wrong patient to think about, well, what happened in that instance, why did that happen, and was I busy, was I rushed, was I tired, was I hungry, what helped to contribute to that, what could I do differently in the future. It also helps us as individuals develop our skills, knowledge, learn from mistakes but also successes, to understand and reflect on your biases and assumptions maybe, and really to help process what's happened and to help get it out can be really helpful psychologically to sort of to process the emotions that you're feeling. But also helps with your CPD and developing your goals for your learning potentially, and to critically evaluate your practice. There's lots of really beneficial reasons to reflect. There are many models of reflective practice, and the one that I particularly like though is Gibbs' reflective cycle. This is now quite old, it's from 1988, so it's nothing new. And it is a guided framework to help the reflective process, and has prompt questions to sort of guide you through that process. So I'll go through those now with you. First of all, we are giving a description of what happened essentially. So we're briefly describing what happened. I've got an example here which is not a real example, but just to sort of give you a guidance as to what we mean by each of these steps here. So the nurse here has said she's made a medication error while giving a prescription to a patient, a 10-year-old lad called Max, who's being treated for osteoarthritis. Most frequently administered a higher dose of the NSAID than prescribed. So that's what happened. The next stage is feelings, so how you felt about the situation, before, during and after, thinking about what these emotions are that you're experiencing. So this nurse felt a mix of emotions following the error. Initially a strong sense of guilt and shame, being worried about the consequences for the patient, and being worried about the repercussions for her. Also, a lot of frustration with herself for making a mistake like this, sort of common feelings that might be experienced in case of medication error. The next stage is to start evaluating the process. So basically what went well and what could be improved. So again, thinking about what did go well, which for the student nurse example I gave earlier was checking with the vet that the patient was okay, didn't need any intervention. So this nurse here has said the error is due to a lapse in concentration, being under pressure to complete tasks efficiently, being distracted by the thoughts, the labels being similar, which could have added to the confusion, but that she did check the vet and make sure if there was any intervention needed. So what went well and what could have been improved. Then turning more to the question of why, what's the analysis of the situation, why things happened the way they did and what the factors were that contributed. And so in this case, I didn't ask someone to double check medication labels and doses before giving the medication. I also hadn't had a break that day and was feeling overwhelmed and fatigued, and not underestimating the impact that being tired and having low blood glucose because you haven't had a break can have on your mental thought process and concentration levels. Then about the conclusions, what the key takeaways are from the situation, what you might have learned about yourself or your patient or your practice. So for this nurse, it was a valuable learning opportunity, has become more aware of the importance of medication administration, the potential consequence of errors, and her commitment to improving her practice and ensuring the safety of her patients. And then finally, the action of what you might do differently in the future, or if something that's gone really well, something you might repeat in the future. So for this nurse, she is going to ask someone to double check her medications before administering them, using the 5 rights as a prompt tool, taking breaks to stop feeling overwhelmed and fatigued, and to participate in CPD just like this, to stay updated on medication best practices. So this cycle is something that can be really helpful to reflect on situations. Again, some of you today will have had a copy of the Reflective Practice Workbook, which we have had printed for you today, to have those sections in that you can do a quick annotation of these reflections sort of close to when the events actually happened, to then be able to put into your online CPD resources at a later point if need be. So quite a helpful little workbook, I hope, to guide you through this process. And so finally, just to summarise the takeaways from my session, is that medication processes are complex and they are prone to error. To use that 5 rights as a mental prompt tool, to countersign everything and double check everything, to, where you can, implement things like tool monitoring, thinking about your leading and training zeros, abbreviations, and to use reflective practice as a learning opportunity when things do occur.